Hello, everyone. Good evening. So welcome to the Mayo Clinic Lead Extraction Workshop webinar, and this is our section 9. My name is Yongmei Cha, the electrophysiologist at the Mayo Clinic. On my side is my colleague, Dr. Siva Mopuro, our current device director. So today we're going to present two very interesting cases. So we invite the outside speaker, Dr. Emily Zeitler. She's going to speak on the first case. And the second speaker is our colleague, Dr. Vaibhav Vaidya. So Dr. Emily Zeitler graduated from Duke University and has been the staff cardiologist at Dartmouth Health. And she is the associate professor of medicine and also the director of device service. In the past few years, she has built up the lead extraction practice at her medical center, and she has contributed significantly to the EP and the device field in the nation. So she's very academically oriented. She has published so many great articles in the field of EP and the device practice. She has participated multiple clinical guideline and expert consensus statement to contribute our clinical practice. So we are honored to have Emily to present the first case with us. Emily?
I'm really excited to be here. This is a really fantastic forum. Extraction is like the wild, wild west. So it's like, what's everybody doing? It's always good to get together and talk about what people are doing because there's so much to learn from each other. So I'm really excited to be here. This is a case that I called a mysterious case of vegetation. And it's a case of Mr. G, who's a 75-year-old man who is a lifelong resident of Upper New England. He has a history of chronic asthma and paroxysmal atrial fibrillation with no treatment for his AFib other than Eliquis for stroke risk prevention. He had a history of complete heart block and got a dual chamber Biotronic pacemaker placed in 2020 at an outside institution. He worked as a carpenter and a contractor, which may or may not be relevant to his case, and he continued to do small projects throughout his retirement. He developed symptoms of cough and shortness of breath in December of 2024. Initially reached out to his pulmonologist who treated him with prednisone taper. Actually, the first one didn't work so well, so we got another prednisone taper plus a Z-Pak, but didn't really have much improvement. So he presented to our emergency room in early February of 2025 and was treated for what was presumed to be community-acquired pneumonia with doxycycline and Augmentin. In fact, it was recommended that he be admitted, but he declined admission at the time and was discharged from the emergency room. He did not get better, though, and so a couple weeks later presented to an outside emergency department and was still feeling quite poorly and had some imaging done which demonstrated right lower lung pneumonia with an overlying empyema and findings of cavitary lesions in his right lung. So he was initially treated with a chest tube with drainage of the empyema and with intraparenchymal lytic treatment, as well as IV ceftriaxone and clindamycin for pneumonia that had presumed to progress. He had imaging of his chest and abdomen, which demonstrated splenic infarcts, as well as embolic phenomena in the lungs. He had an echo done that demonstrated a very large vegetation in the right atrium. It was unclear at the time what it was connected to, but it was seen on the chest wall echo. So at that point, his infectious workup was pursued in earnest, as you might imagine, but initial testing was negative, which consisted primarily of blood cultures, urine culture, and sputum. His empiric treatment was expanded to include antifungals because of the size of the vegetation and concern for fungal infection. And he ultimately, it's a bit out of order, but ultimately had an MRI of his brain and spine. Given the findings in the spleen, there was concern there might be embolic phenomenon or abscess in the spine somewhere because he was complaining of some back pain. You can see here in the table on this slide, this is his hardware. So he had a Biotronic system. Everything was implanted in 2020 at an outside institution. So the first thing, as an extractor, you want to see the TEE. So it was not all that subtle. As you can imagine, this TEE had about 4,000 pictures in it. So I've chosen one here to demonstrate the very large vegetation in the right atrium. And there were at least two vegetations. One appeared to be attached to the right atrial lead and one to the right ventricular lead. You'll have to take my word for it that we didn't see anything attached to the valve itself. And on the right-hand side, this is a still image with a measurement. There were many measurements of this thing made. They ranged in size from about 2 centimeters to close to 5 centimeters. But we can all agree it's just big vegetation. So this TE was done at an outside institution, and they recognized that the size of this vegetation would make it potentially quite dangerous to do percutaneous extraction without debulking. So they did consider debulking procedure. They considered open extraction, but just didn't have the resources to get it done in a timely fashion. And I think that's often a pretty consistent theme in extraction, is getting the resources that you need to do the safe procedure. It can be really, really challenging. And so the extractor at this outside institution reached out to me, and we talked through the case and decided that it would make sense for the patient for him to be transferred for more expeditious percutaneous debulking and extraction. So we came to our institution, and I'll pause the case there and talk a little bit about what we thought about for options of percutaneous debulking. There are some centers that have a lot more experience with this than my center, but we do some. And it really boils down, in my mind, to two approaches. And a lot of what we know about debulking comes from the literature on endocarditis without indwelling leads. And the big division is between on-pump versus off-pump debulking options. There is quite a bit written in the literature about AngioVac being used for debulking, and this is an on-pump option. So the advantages of that approach is that you get continuous suction. And so you don't have to really concern yourself with how much blood loss with each suction event as you do with the off-pump option. So you get continuous suction, which results in pretty insignificant blood loss. You can see the circuit on the right. This is the AngioVac circuit that I'm showing you. And so all the blood that is removed is filtered and then returned. The problem here, of course, is that if you have a really large vegetation and you clog the circuit, you have a problem because you can lose all the blood in the circuit. It also requires pretty large access, typically one in the neck and one in the groin, although there are other approaches. And so the off-pump approach is really the reverse of all of that. So the advantages are you don't need a bypass circuit, and so there's less exposure to heparin. You don't need quite as high of an ACT. It's a single access, but the downside being that you can't easily return the blood, and in most cases we don't. And it can be more technically challenging because you really each suction event is higher stakes because you're removing blood with each suction event, so you have to be more precise. I'm aware of a few different off-pump options. I'm curious if the audience has other ideas or experience, but some that I'm aware of is the Inari, the Penumbra, the AlphaVac. There may be others, like I said. The literature is a little thin here. It's mostly case reports, and so this is the kind of forum why maybe we can learn more. But we chose the AlphaVac for this case. Here's the AlphaVac system. This is the one we chose based on our prior experience with good experience with it. So the assembled system is in A. So you can see it's a handle with a sheath, and the sheath has a funnel at the end. Down in C, you can see the different shapes of the funnels. You can get a 20 degree or 180 degree. This is a fixed shape. And the funnel is, in the largest version, is 42 French, so it's quite large, and it's really soft at the tip. So you can move it, pretty easily throughout the atrium. And the handle allows you to toggle between 10 cc and 30 cc suction. So you get, we use the 10 cc function sort of as the hunting mode, looking around for things. And sometimes if you use the 10 cc, you can feel that you're on the vegetation. And when you pull on it at 10 cc's and nothing comes back, you can imagine that you might be sucked up against the vegetation. And then you can switch to 30 cc's and really give it a go to try and get it sucked into the waste bag. This is how we set up our procedure. I'm always fascinated with all the differences in how extraction cases are set up. So I thought I would share our setup in this particular case. We did this case in the hybrid lab. We don't always do that, but given there were so many pieces to this case, we wanted the extra room. And so we, made a deal and got access to the hybrid lab. We had perfusion available and we had cardiac surgery available. They were not in the room. General anesthesia was provided by the cardiac anesthesia team in order to provide TEE guidance, which we always like for our extraction cases, but particularly if we're going to debulk because you require guidance for our debulking mechanism. So we induced anesthesia, and then the interventional pulmonary team actually piggybacked onto the case in order to get a BAL done. And then after that, we advanced the TEE in order to get some pictures of the vegetation to allow us to make a decision about whether to approach it from the neck or the groin. With the AlphaVac system, if the vegetation is attached to the valve or it's very posterior in the right atrium, it can be very difficult to get there from the groin. So we wanted to make sure we would have a good approach, whether it was from the neck or the groin. And this one looked like it would be pretty gettable from the groin, given that it was attached to the lead and it was mostly on the atrial side. So then we prepped and draped. We got our groin access, including large bore access for rapid resuscitation if needed. We placed a placeholder for the bridge balloon, which we do for every case. And then we placed a 26 French gore dry seal, and we pre-closed that ×2. And then we heparinized to an ACT target of greater than 250. And this is the video I'm going to show to my grandchildren someday. But if you watch this loop on the left, you can see there's the large vegetation. And here's the funnel coming in from the groin. This vegetation gets sucked up into the funnel right at the end of the loop before it goes back around. Play that a couple more times. And then after we removed it, and we actually also debulked the vegetation on the atrial lead as well. And this is what we were left with on the right. It can be really kind of addictive once you remove the vegetations. You want to keep going. But you have to remember that there's a lot of blood loss when you do that. So we really have to, pause after each suction and say, well, what's left? Is this something that we would have debulked if this is how it looked at the beginning of the case? And when we got to this point on the right, we felt like that was not something we would have debulked. So we decided that was a point we were going to stop and move on to the extraction procedure.
One question from the audience here is choice of imaging, like using intracardiac echo versus TEE. What are your thoughts for that?
Yeah, I think it's a really good question. It's one that we considered. I think there are scenarios where intracardiac echo would make a lot of sense. To be honest, I was worried about putting more things into the atrium with this giant vegetation flapping around. I was worried that we would knock the vegetation off if we put ice up. In fact, I was so worried that, this is a dependent patient, and I thought, well, if we suck on this lead, are we going to dislodge it? Do we need to place a temporary pacing catheter before we do the debulking? But in discussions with the angiodynamics team, they said they really had not ever seen that, so we felt comfortable not placing backup pacing, and so we deferred ice in this case because of the size and the pedunculation of the vegetation, worried that we would dislodge it.
So it seems you have done quite a few cases with the AlphaVac, right? So
I don't know about a lot, but a handful, yeah.
Yes, handful. That's great. It's impressive. I can see that the imaging from the echo right away, the big chunk of clot is just gone. So that's very nice to see. So do you have any criteria, and the size usually above 1 centimeter, 2 centimeter, you would try to do the debulking?
I think that's also a good question. And I think I'm talking to the right person when I say, I hope that the guidelines will help us with this in the future, because I don't know the answer. The prior expert consensus in 2017, which I'll show a snapshot of in a second, but, it says at 2.5 centimeters, you should think about, at that point, basically think about open extraction. And I don't know that anyone is, in the all things being equal, I'm not sure I know anyone or any programs that are routinely going to the OR for open extraction of vegetations that size. But I use that number in my head, about 2.5 centimeters. Anything bigger than that, I would definitely consider debulking. And I think given the safety that we've seen with these percutaneous debulking tools, I think we probably could lower the threshold further. I know there are some programs that would consider this even for anything greater than 1 centimeter. And I don't think that's wrong because really they're quite safe. So it's a moving target in my mind.
Thank you. Continue your case.
Okay, so this piece of what looks like chewed up gum was the largest piece of vegetation that was removed. It was really organized, suggesting that, it'd probably been there for a long time. We removed some other bits as well, as I mentioned, from the atrial side, but this was the largest one. It measured about an inch or, a little over maybe 2.25, 2.5 centimeters. We sliced and diced it on the back table. There was a very threatening consult note from the infectious disease team about all the things they wanted us to check. So we did our best to comply with their recommendations and sent off 1 million different tests. Then the nice thing about this was, because he was culture negative, I felt comfortable placing a leadless pacemaker right then and there before we moved on to the extraction. And the Micra leadless pacemaker can be deployed through the 26 French dry seal. So we use the same access to deploy a Micra, which was done, uneventfully. And once we placed the Micra, we removed the dry seal from the right groin and reversed heparin so that we could move on to the extraction procedure. We staged the bridge balloon, which is, per our protocol, and then moved on to the pocket. We opened the pocket, which appeared normal, but we sent 1 million more samples to the lab and moved on with our lead prep.
Dr. Ziegler, Dr. Mayton has one question here. What about the appearance of the vegetation in addition to the size? Did you find anything particular to this vegetation? Is there anything high-risk features of a particular vegetation, the morphology rather than the size?
I think that I don't know that we could ever really appreciate the stalk of this vegetation, but certainly something with a thinner stalk, that is really pedunculated, really flapping around, would be more worrisome to me in terms of embolus. It also, conversely, makes me think that it will be easier to debulk percutaneously. It's challenging to get the timing right for something that's flapping like that with each heartbeat, with cardiac contractility. You have to get the timing right to debulk it. But if it's really sessile and stuck on the lead, then you really don't have a chance at debulking it as much percutaneously. Or if you do, it's sort of like it's more laborious. It's lots of passes, little bits at a time, and then there's a lot more blood loss. So this case in particular demonstrated what I thought to be a high-risk vegetation that was also quite amenable to percutaneous debulking. Once we had the vegetation on the back table, I was surprised sort of how well circumscribed it was, like how organized it was. I thought it would look kind of choppier if it was, acute, infection. It sort of seemed so organized. It made us think it had been there for a long time, and that maybe it had developed thrombus on top of vegetation over time. And that may have accounted for some of the emboli we saw. So we prepped our leads per our routine. We had tried to withdraw the helix on both leads, and that failed, which, is typically the case. We cut these leads. I don't cut all the leads, but we cut these, and we put easy lead locking devices down each one. And then we cut the insulation, we secured the insulation with fiber wire using a constrictor knot and some half-hitch knots. And I always do 4 knots for no reason at all. It's just the number that I do. And then we use the 14 French laser. These leads came out super easy. I'm showing you here the removal of the atrial lead, which we targeted first. There was some binding. You can see what I'm showing here is the lead-on-lead binding in the innominate vein. But other than that, these leads came out really easy. The pocket looked benign, so we irrigated it and closed it primarily. We sent all the hardware off, including the generator, and then we removed groin access, and we were done. He recovered from the procedure quite well. He's not doing so well clinically, though, continues to struggle with malnutrition, mostly due to nausea, which we think may be due to the itraconazole. And the diagnosis remains somewhat uncertain. This is mostly just for effect. I'm showing you all the things that were sent off from this vegetation and from the hardware. I checked the chart actually this morning just to make sure I had everything up to date. And the generator that we removed was sonicated, which I'm told increases the yield by about 30%. And that is now growing coag negative staph and is the only positive finding so far, and uncertain whether it's real, but that's the only thing we have, only thread we have to pull on. Everything else has been negative. This is what I mentioned before. The 2017 expert consensus provides some guidance about a threshold of 2.5 centimeters. But this is a moving target, and I for one, am not sure what the cutoff should be, when we should be considering debulking, and when we really should just be going to the OR for open extraction. In the 2024 scientific statement on lead extraction from AHA, percutaneous debulking is mentioned, but there are no clear guidances for when and how. In the literature, it's a little bit all over the map. It's mostly case reports. There are some observational series, many single center, some multi-center, but numbers are all pretty small. I would summarize the findings by saying that mostly what's reported is with the use of AngioVac, so that's the on-pump debulking system. And in basically all cases of all the reports, the safety seems to be quite high. Success is also quite high. But, in the absence of really rigorous studies, it's tough to say whether whether this is better than a lower threshold for open extraction. There are some large lead-related vegetations that can safely be debulked percutaneously, but data supporting the strategy are observational, and guidance hopefully will be forthcoming. Multidisciplinary cooperation is so critical. Just like all things about lead management, this was so many people involved in trying to work up and diagnose this culture-negative endocarditis, and we still don't have an answer, and there are so many people involved. And that's sort of on the clinical side. And then on the procedural side, this was super complex to coordinate all of these teams, the perfusion team, the AlphaVac team, the Micra team, the anesthesia, the cardiac surgery. There were so many people involved. It was really complicated, and I'm so grateful that it all came together. I have a really great team. And that's all I've got. Thank you so much for the chance to present the case. I'd be happy to take questions.
Well, Emily, that's an excellent case. So it seems that, you really put a lot of thought for this case going through, because I can tell, how to organize this case from the get-go. And then you decide to do the debulking. But this patient basically has a pulmonary infection, but is culture negative, right? Culture negative, so we don't know if patient truly has bloodstream infection or not. We don't know. But definitely it's a large vegetation on the lead given all the situation. So you decided to pursue the lead extraction. So one question that I have for this, patient does have a systemic, embolization, right? So then the question, did you mention about if patient has a PFO?
Oh, good question. We looked really hard for a PFO and did not find one.
Okay.
Yeah. So the splenic infarcts are really mysterious. In fact, I had one of our vascular surgeons look at the CT scan of the abdomen to see if there were just like good old-fashioned plaques in the splenic artery that could explain maybe this was just emboli from atherosclerotic plaque, but there was nothing there. So, I don't have an answer for it. It really took us down a rabbit hole. That's why we pursued basically a whole body MRI, looking for other sources of infection on the, left-sided. So I think there are a few different possibilities. One could be that there was a left-sided lesion that embolized and is now gone and has showered the spleen. Another is that it's unrelated. Perhaps he had left atrial appendage thrombus from his atrial fibrillation. He'd been off anticoagulation. Perhaps it was just, thrombus that had embolized. But I think, you and Dr. Mulpuru brought up the possibility of shunting in the lungs through these cavitary lesions, and that is not something we had considered. It's a really interesting hypothesis. I think it's just as good a hypothesis as anything else we have to work with. I'm sorry. It's just curious that it really was just the spleen. So I don't have an answer for what appeared to be systemic emboli. I'd be curious if there are other thoughts.
Dr. Zietler, one question from the audience is about, reimbursement. How did you manage that, with your teams? Is there a special code for this?
Maybe. I'm embarrassed to say I have no idea. This was a ask forgiveness situation and not permission. There was a lot of enthusiasm to do the case, and I honestly don't know, but I'd be happy to find out. I'm sure the angiodynamics folks would be happy to provide some billing advice.
Thank you.
Yeah, in our institution, I think for the thrombectomy, we often use is AngioVac. So every institution is different. So, let's check with the audience. Anyone want to have a comments? I think many of you have experience on the debulking and thrombectomy. If anyone want to comment on this with your experience, welcome to speak.
Yeah, most people are saying great case, so well thought out plan. Yeah.
Yeah, it's a wonderful case, and it's very successful, and then the patient's doing well apparently, right? Yeah.
So we also have Dr. Vaidya. Maybe Dr. Vaidya, if you have any questions or comments, and then I will introduce you after that.
Yes, can you hear me? Well, one question, Dr. Zietler. In the presence of PFO, does your threshold change for debulking?
I think that's a really good question, and certainly the literature would support that. In some of the case series, the threshold for debulking is generally about a centimeter lower in size if there is a presence of a PFO, which I think makes good sense. And in fact, in this particular case, given the size of the vegetation, we interrogated for PFO extensively prior to performing the debulking because I was worried I might knock this thing off and it would, cross a PFO. So, but I think in the presence of a PFO, it is totally reasonable to have a lower threshold. Again, maybe about a centimeter less, like, 1.5 to 2 centimeters might be big enough to justify debulking in that setting.
Yeah, it's a critical point. I think if a patient does have a PFO with the right to left shunt, then probably we may consider to close the PFO. That's probably it's an appropriate step to avoid the paradoxal embolization, if that's the case.
Absolutely, yeah.
Great.
Good.
Thank you for presenting. And please stay on, and we
love your comments for the future case.
Yeah.
Sure, happy to. Excited to hear.
Okay, so it's a pleasure to welcome my colleague, Dr. Vaibhav Vaidya. He is a practicing electrophysiologist, chair of cardiology at the Mayo Clinic Health System in Eau Claire. Vaibhav has interests in complex device procedures, lead extraction, and he's also a great, clinician, great to his patients, colleagues, and he's going to share a great case with us. Dr. Vaidya, thanks for joining us today.
Thanks so much for the kind introduction, Dr. Mulpuru and Dr. Cha, and thank you for inviting me. Terrific presentation by Dr. Zeitler. It's great to learn about the options for percutaneous debulking. Our case is going to be, a little bit more focused on the clinical aspects of identifying an issue and then what we can do to help our patients with it. And we want to keep things interactive. I have a couple of things in there where it's kind of like a question to the audience. So feel free to drop in the chat or drop your questions in. And of course, our panelists to, stop me if there's a topic or area that we need to discuss further. So we'll get started with the case presentation. So our patient is 37. She's a 37-year-old lady with a familial non-ischemic dilated cardiomyopathy. Her left ventricular ejection fraction was 22%. And she had received a primary prevention single chamber ICD in 2020, which was left-sided. So I have not put the device details in, but it was a Medtronic system, and it was a single chamber, single coil ICD that she had received. She also had an appropriate shock. A few months after having the device, she had nocturnal episode of ventricular fibrillation that was appropriately shocked, and then no events since that time. And then a couple of years after the implant, she started complaining of these symptoms. She had facial warmth, flush sensation, said she was short of breath when she exercised, started having headaches, just overall feeling full. And her words were vocal cords feel tight. And she was very bothered, with these symptoms that are going on. So at this point with this history, who should we consult next? Should we get cardiology on board, cardiac EP, or neurology with the headaches, or ENT with the vocal symptoms, or psychiatry because the symptoms, are hard to tie together? Or maybe our friendly neighborhood hospital administrator. It's okay, I can make fun of them because I'm part of the group now. So that's more of a jest question, but we do have audience questions going on. So she did actually end up seeing ENT. She was referred to ENT, who ruled out any vocal cord spasm. She also saw neurology, who made a great clinical point that her headache actually, had improved by lying down, but they still did imaging, and there was no evidence of cerebral sinus thrombosis or no papilledema. So, they did not have a clear explanation for her symptoms. She also had an echocardiogram that showed that the ejection fraction was unchanged. The IVC was collapsible, so it did not, clinically look like heart failure. And also had a CT angiogram of the head, neck, chest. And the read was that there was no definite evidence of SVC syndrome. I'm sharing some of the images here, and you can see that there does seem to be some channel for the blood to flow through next to the lead, but it can be a difficult assessment, with all the blooming artifact that's present on the CT scan. So what is the next best step here? So actually what ended up happening with the patient is, we looked at the physical exam more closely. It's interesting how, this diagnosis came about because, the patient actually had multiple emergency room visits after these consults, and one of the emergency room physicians actually identified that, hey, something may be going on here that's vascular in origin, and referred to our vascular surgeon who did the physical exam and then got a hold of me because the patient had a lot of facial rubor. And, there were dilated veins, the EJV, external jugular vein was dilated, got even more dilated with Valsalva, and there was no edema noted. But these were unusual features. And the thing is that when not every provider saw this because the rubor would come and go. And that was another point where we asked her to take pictures of when this would happen. And then it was very clear to everyone that there was a lot of facial rubor present that correlated with the symptom. Just pointing out the dilated veins there in the EJV and along the temporal area. So at this point, what would you say is the most likely etiology of the patient's symptoms? Is it heart failure, thoracic outlet? Was it an allergy to contrast or food, or SVC syndrome, or venous sinus thrombosis, or a functional disorder?
The audience were saying, you really listed all the differential diagnosis for this condition, right? Maybe just go through one and tell us why that particular thing is not on the top of the list. How did you rule out those particular conditions?
Absolutely. I think that's a great one. So for heart failure, we know it's a clinical diagnosis. So on examination, yes, jugular venous distension would be one feature, but then we would also expect crackles, lower extremity edema, those kind of findings, otherwise seem very well compensated, on exam from that standpoint. She was NYHA class 1 otherwise, symptoms were very typical in that they would not happen with lower extremity exercise. It's upper extremity exercise, that would make things worse. And for thoracic outlet syndrome, it may be more limited to one limb, to one extremity. And here kind of, it was more facial, the symptoms that she was having. And allergy to contrast or food is kind of what's brought up in the notes. But really, there was no correlation to her CT scan or anything of that sort. In fact, it was done because of these syndromes. And the big one that in the chat also folks are saying is SVC syndrome. That is the one that we get most concerned about when we hear these symptoms. But part of the case is to illustrate how elusive, sometimes that diagnosis can be. And it's this unusual constellation of symptoms that should raise our clinical suspicion for SVC syndrome. Venous sinus thrombosis, with headaches, I think it's a fair thing to keep in the differential, but we got imaging for that, and that was negative. So that made it unlikely. But what was difficult at this point in the case is the CT scan had showed that, there was maybe no SVC syndrome. So where do we go ahead? How do we move forward here, where our clinical suspicion is very strong, for a diagnosis, but the imaging doesn't quite back it up? So actually what we ended up doing is our vascular surgery colleague, Dr. Sen, and I think she might have joined the webinar, I forwarded her the link. She did a diagnostic venogram. Instead of the CT scan, did a diagnostic venogram, which we are showing here. So we're seeing the contrast come in from the left subclavian axillary system. And here around the level of the SVC, we do see a waste and a constriction, over there. And the feature here that suggests this may be hemodynamically significant is also the collateralization. We are seeing all these collaterals kind of open up. The azygous vein that we see over here is very dilated, and the contrast actually is going kind of retrograde into that azygous vein. All of these are features that there is a hemodynamically significant obstruction in that area. So again, showing, that area with the SVC stenosis with the collateralization. And although this was diagnostic, since, we were there, elected to go ahead and perform a venoplasty for this. And post-venoplasty, stenosis was reduced, the collaterals were reduced. So in summary, this had confirmed this high-grade focal SVC stenosis. IVUS was also performed, which I had not seen before, but it is more commonly performed in vascular surgery now. That did demonstrate webbing, in that area of stenosis, which seems to be a feature, when there's this significant stenosis present. And then there was luminal gain after venoplasty, and the symptoms, quite immediately improved, which is something that we see again in SVC syndrome, is that the symptoms tend to improve. And that just told us that, yes, clinically we had the right diagnosis over here. So she was discharged on Plavix for 12 months, but, had a recurrence of symptoms. In a few months, symptoms came back while they had improved initially. So what would be the next step at this point? Would we just repeat SVC venoplasty as needed? Should a stent be placed in the SVC, jailing that ICD lead? Should we extract the lead, place a stent, and then reimplant through the stent? Or should we extract, do a venoplasty and, consider completely extravascular system where feasible, like an SICD?
So people are saying either 3 or 4 option. Maybe you take us through.
Perfect. That's great. So what we elected to do is, yes, we elected to extract the lead. We did not want to jail it. I don't have a lot of images from the case itself, but, I'll walk you through kind of, very standard how we do it. We do our cases in the hybrid OR with cardiac anesthesia. TEE is available for monitoring for all the cases. And actually, our cardiac surgeon and I kind of co-scrub, so that's the best case scenario where he's right there, if any issues arise. So we do these cases together. And for this one, of course, our vascular surgery colleague, Dr. Sen, was also present. So could not retract the helix. We prepped the lead as usual with a locking stylet. And, just based on traction on the locking stylet, it looked like there were adhesions in the subclavian area. We just decided to use the tight rail device. And with that, we were able to completely extract the lead. We did retain access with a guide wire and image of the lead that was extracted. The retained guide wire, we did have a shot of that along with the stenosis present. And what was done after that by our vascular surgery colleagues is they did go ahead and perform the venoplasty. And following this, when they measured a pressure gradient, there was almost no gradient across that area. And we had already talked with the patient, about the stent option. My thought process there was, if we can get away with a completely extravascular system, we should prefer that option. Because even in the literature with stenting and placing a lead through it, there are cases where there's in-stent restenosis. So overall, we wanted to take a more conservative approach, considering her young age, to be as extravascular as possible. Her clinical arrhythmia was VFib. She had not had VT, so no need for ATP, no need for pacing therapy. Screened in for an SICD. So the decision making we had laid out is, yes, we'll go ahead and do SICD at the same time after extraction, and we'll decide on stent kind of on the table. But, with the result on the venoplasty with very little gradient, elected not to stent, and we went ahead and performed the SICD implant. With a thought that if there is recurrence, even with the lead out, then we can always do stenting down the line. But otherwise, if it's not required, we don't have to have anything permanent in, on a young person. So she's been doing great. At 1 year follow-up, she's been asymptomatic, no recurrence of those symptoms, no appropriate or inappropriate shocks at the current time. So glad that she's doing well.
If this patient either require pacing or has some monomorphic VT, right? So you may have to go through the transvenous ICD. Then what you do?
Absolutely. I think with the currently available technology, that is what I think most centers will have capability for. But that's where I feel pacing is exciting. There's always evolution around the corner. So we know that the modular ATP trial was done, with subcutaneous ICD and leadless pacemaker through Boston Scientific. Now it's not approved, and we'll have to look at trial data and results. But I think at some point in the future, we will see more extravascular ICD options coupled with leadless therapy for ATP parts of the treatment. But yes, at the current time, that's probably what we would have done if she had monomorphic VT or a pacing need, especially like a resynchronization type pacing need. Then I think we would have had to stent and then go through the stent for the device. So a few points on SVC syndrome. It's not common. It's not very common. In published series, it's less than 1%, chance of this happening after device implantation. And there's some very typical kind of historical features here. The symptoms are, they can sound strange. There's these atypical symptoms like vocal symptoms, hoarseness, headache. All of these have been reported in the series that have talked about lead-related SVC syndrome. And the clinical features are that, it's not worse with exercise as such, but it's worse with upper extremity activities. So that's something to ask the patient, when you're showering, taking care of hair, putting things, when you're doing up your house, working on shelves, all of that, carpenters or electricians working above your head, what happens with the symptoms? They also worsen when bending forward or supine, and they can come and go. Like in our patient, sometimes when you saw in clinic, look completely fine, but something may be changing with the hemodynamics, with more fluid burden or what was going on that day. And on certain days, the symptoms were worse, and that was clearly evident in the pictures, that she had provided us. So these are some of the historical features to look for to kind of have that strong clinical suspicion. And what are the risk factors? Multiple leads, longer dwell time, hypercoagulable state, all of these are risk factors for SVC syndrome. Venoplasty alone has a high rate of recurrence. In our case, we did that, because we were there and, wanted to get a sense of whether the symptoms would improve with it. which they did, which was helpful to know. But venoplasty alone with an indwelling lead, that's still there, very high rate of recurrence, and that's been reported as well. If we look at the 2017 consensus statement for lead extraction, it is recommended to extract a lead when the stent is planned, to avoid entrapment of the lead. So we do want to avoid entrapment where possible, by extracting the lead if a stent is planned. And lead removal can be a part of a comprehensive plan in patients with SVC stenosis, with occlusion or limiting symptoms. So these two are class 1 in the guidelines. So there are some controversies here still. It would be great to kind of discuss this, get the panel's thoughts, get the audience's thoughts, and get your questions. The first one is less of a controversy, jail or not to jail. We just looked at the guidelines, but more is are there circumstances where you would rather jail, is kind of a question. I can just answer it myself. I'd love to hear Dr. Mulpuru, Dr. Cha, Dr. Zeitler thoughts and the audience's thoughts. I guess only point would be if someone's comorbidities are so much that you would rather avoid a lead extraction, life expectancy is lower, but clearly has symptoms. That's the only circumstance I would think where I would jail the lead. Otherwise, I think we would always try to extract.
That's right. If you jail, you make the subsequent extraction almost certain to be an open extraction. It'll be very tricky to be able to extract that jail lead if it ever were to get infected in the future. But we're seeing more and more jailing with the new tricuspid valves, right? Routinely, but that's intracardiac, and I think time will tell whether those leads that are jailed with these EVOQUE valves would come out or not.
That's a terrific point. We've not been doing those, but I think all of us will encounter that more and more in our clinical practice. So then the next question becomes, should we stent or just do venoplasty alone? And like we saw in this case, if the lead remains in place, the risk of recurrence is very high with venoplasty alone. And I think if the lead is going to go back across the SVC, we almost always have to stent, because we remove the lead to facilitate patency of that SVC. So if a lead is going to go back across, I think most folks would probably stent and then put the lead through the stent. But if we are going to a completely extravascular leadless based system, then I think a case could be made in venoplasty alone, because now the offending or the inciting factor no longer exists. And like we saw in our case, did well for a long period of time now, for a reasonable period of time now. And you can always go back and stent, So that's kind of where we land, and curious if there's thoughts on this.
Yeah, that's true. I think the venoplasty, the recursion rate is very high. So, but from the interventional radiologist standpoint, that they probably still trying to do the venoplasty at least 2 or 3 times and continue to have recurrence, then we go for the stenting. Yeah, so that is the situation. Now, one thing I noticed that in this patient, did you give a platelet, antiplatelet medication, right? Plavix. Anything kind of supporting anticoagulation versus antiplatelet in this setting?
Yeah, that's a great question. Yeah, it's a great question. I think I'm not aware of evidence in that area, and there's not like a acute thrombosis or anything of that sort. So we didn't see a clear need for anticoagulant. I think just in vascular surgery literature, just very common to use antiplatelet, from what I've seen after plasty. And, we were in close collaboration with our vascular surgery colleagues, so elected to use Plavix at that time. But I'm not aware of any strong data in either direction.
Dr. Vaidya, so, the SVC is a pretty big structure, right? What do you think is a mechanism for such a thin lead causing this SVC like the focal obstruction? And what does that webbing mean? How is that forming in these patients? Any thoughts?
That's a great question. Whenever there's occlusion, you wonder if it's something acute or something that's developed slowly over time. So in the smaller vessels, I think the mechanism may be like a DVT, even like a subclinical DVT that develops and then fibrosis over time. But the SVC is such a big structure, an acute thrombus would, almost, doesn't happen, that commonly. So I think the mechanism here is probably like intimal hyperplasia. The lead may be irritating the the inner layer of the SVC, and we may be getting like hyperplasia, of that area. That's my theory for why this happens. And then there may be areas within that structure that once they start to have that response, that just increases. And then that is the section of the SVC that ends up stenosing. So any kind of anti-proliferative kind of treatment, may help at some point with this. But, clearly more work is needed, I think, to define that mechanism.
Yes,
Maybe Dr. Zietler also has any
Do you
comments,
have any comments?
on the etiology.
The thing that was really surprising about this case was that this patient had such dramatic SVC narrowing with just one lead. I feel like the cases that I've seen of SVC syndrome, or the cases we worry about it, I suppose, are in patients with multiple leads. And I'm wondering if there's any thoughts about, if there are particular things about a specific patient or other vascular concerns or abnormalities that would predispose somebody with just a single lead through, we've already talked about the significant size of the SVC and why one lead in such a young patient would cause this level of stenosis. Perhaps it was partially covered in the last question, but I'm just curious if others have had experience with a single lead causing this level of stenosis.
Yeah, that's a tough one. It's a great point because absolutely, with a single lead, it's hard to see that degree of stenosis. Somehow I've just noticed in younger patients with defibrillators or pacemakers also, even at the time of generator replacement, some of them just have this hyperproliferative kind of response. I mean, the capsule is kind of extremely thick, so there may be something about kind of a maladaptive kind of response in some folks, even with a single lead. Hard to explain. We did not look for a hypercoagulable state in her, but it seemed less likely that this was thrombus. So it's difficult to explain this one completely. Open the thoughts on it.
Some patients can have like a congenital vascular webs, and if you're going through a pre-existing web and a low flow, that can exacerbate the degree of narrowing.
That's a good thought, but it's hard
That's
to
a good
prove.
thought.
Yes.
Hard to prove. Yeah.
Last one, I think we already had discussion around this is, should we do transvenous lead after a stent or prefer leadless systems? And I think most folks, if there is an option for a leadless or extravascular system, that would probably be a prudent course to take. But if the technology doesn't exist or is not available, then I think we're committed to transvenous options.
It's a great case. It's several learning points there. And I think today you reinforced Dr. Nishimura's teaching. When your diagnostic tests don't make sense with the physical examination, go with the invasive test, which is your invasive venogram. Thank you for sharing that case, Dr. Vaidya.
Absolutely. Thank you for inviting.
It's really a clinical, it's not that complex, but it's a real world case. It can be troublesome. It takes the time to figure it out and to manage it, through the process. Any comments from the audience?
Audience, everyone's saying great cases, and we covered a lot of good points. Yeah, thank you. We want to thank you both for taking the time to join and present these cases and join us for this discussion. We learned a lot from you. We haven't done an AngioVac case, and thank you for teaching us that, and we look forward to learning from that experience.
Yes, you did. And also, thanks for all the audiences. After work time, I'm glad to see so many people doing lead extraction and join this workshop webinar.
So we'll come back and join. We do this webinar, every few months. And if you have new topics that you would like to hear from us, or if you want to present a case, please let us know. We want, the goal for our conferences or webinars is to increase audience engagement, to create a dialogue for these complex cases. Again, thanks for joining today. Have a good evening.